Let's talk about nausea and vomiting in pregnancy. So definition, persistent vomiting, not related to other causes, acute starvation, vomiting is greater than 3 times a day, large ketonuria, discrete measure of weight loss, greater than 5% weight loss or greater than 3 kilo of weight loss. Mean onset 5 to 6 weeks, peak at 9 weeks, abates by 16 to 20 weeks, 20% persists into third trimester. The incidence is about 3%. Risk factors, multiple gestation, high dentiform mole, non-use of multi-pregnancy before 6 weeks of pregnancy, GERD, genetic factor, female fetus, alcohol or smoking can decrease the risk. Pathogenesis, increase in HCG. Sometimes you have pyloric infection in the past or present. Genetic factor, we need to rule out other causes. GI, you have fatty liver, pregnancy, pancreatitis, appendicitis, hepatitis, peptic ulcer disease, in which you can give antibiotics and H2 receptor antagonist during pregnancy. GU factor causes pyelonephritis, ovarian torsion, kidney stone, metabolic causes. If the TSH is low, we should not treat hyperthyroid unless there is intrinsic thyroid disease, because HCG is a thyroid stimulator. Gestational transient thyroid toxicosis limits the first is limited to the first half pregnancy, and it's not no treatment is needed. Diabetic ketoacidosis, hyperparathyroidism, neurological causes, migraines, pseudotumor cerebri, drugs can cause it, cannabinoid hyperemesis syndrome, or psych disorder. So what are the maternal or fetal effects of hyperemesis? You can get Wernicke encephalopathy with B1 deficiency from the vomiting, splenic avulsion, esophageal rupture, pneumothorax, acute tubular necrosis. You do have a lower rate of miscarriage, but a higher rate of low birth weight and premature infant. Presentation, hypokalemia, hypochloremic metabolic alkalosis, hemoconcentration, elevated BUN, creatinine if severe, elevated ALT, usually it's less than 1,000. Elevated amylase, transient hyperthyroidism usually resolved by 18 weeks, low magnesium and calcium. Treatment, dietary small frequent meals, avoid fatty or spicy foods, bland dry food, high protein snacks and crackers in the morning. Avoid stimulants. Ginger can help with nausea but do not reduce vomiting. Medicine. Early treatment is recommended. If patients vomiting and can't tolerate pill, rectal suppositories are available. Phenothiazine, which is promethazine or Phenergan. Phenergan suppository. Serotonin antagonist can be used as oral dissolvable tablets, Zofran dissolvable tablets or patches, granisetron. Parallel use of D2 antagonist such as Reglan, metoclopramide, and Phenergan together may result in increased risk for extrapyramidal effects, or rarely sometimes neuroleptic malignant syndrome with fever, confusion, rigid muscle, autonomic nervous system instability. Serotonin inhibitors with Phenergan may result in potential cardiac risk of QT prolongation. So you can't, basically Phenergan, you can't combine it with Reglan or Zofran. B6, it can reduce the severity of vomiting, but minimal effect on mild vomiting. So phenothiazide, promethazine is a H1 blocker. Primary H1 blocker can lower seizure threshold, can cause dystonic reaction, especially when used with metoclopramide. Extrapyramidal effects. Dopamine antagonist. So metoclopramide is a dopamine antagonist. It does cause less drowsiness, dizziness, dystonia with Reglan, complication, dry mouth, drowsiness, dystonia, sedation. If used together with promethazine, it can lower seizure threshold and cause dystonic reaction if high dose or prolonged use. Serotonin antagonist, more effective than Unisom, which is B6 plus what is that medication called? The antihistamine. Common side effects: headache, drowsiness, fatigue, constipation. It can prolong QT interval, cause hypokalemia. We do not give IV more than 16 milligrams. It can, there's if used in the first trimester, there is a possibility leading to cleft palate and cardiac defect, but the risk is 0.03%. Steroids, methylprednisolone 48 milligrams 3 times a day for 3 days, followed by a taper for 2 weeks. First use of methylprednisolone is associated with oral cleft. It's a last resort. Dextrose and vitamin should be given if long-term nausea vomiting. Diamonds should be administered before dextrose to prevent Wernicke encephalopathy. TPN, potentially life-threatening because of increased risk for sepsis and thromboembolic events. Enteral tube feeding initially should be used to provide nutrition support. PICC lines can cause cellulitis, line infection, failure, pain, superficial thrombophlebitis, bacteremia, most common major complications. Zofran pumps, there's limited data. So let's take a look at the flow chart. Okay. So first line therapy, non-pharmacologic options. You can do ginger capsules, 250 milligrams, 4 times daily. Can consider P6 acupressure with wristbands. Pharmacologic options, B6, 10 to 25 milligrams oral. And it's given alone or in combination with doxylamine, 12.5 milligrams orally. 3 times a day, adjust schedule dose according to severity of the symptom. Or B6, 10 milligram, and doxylamine, 10 milligram, combination products, 10 tablets orally at bedtime, up to 4 tabs per day. 1 tab in the morning, 1 tab in the afternoon, and 2 tabs at night. So usually we have to use the separated product because this is not paid. This is not paid for by the insurance. So you just do B6, 10 to 25 milligrams TID or QID plus 12.5 of doxylamine. You can also add the following: dimenhydrinate, 25 to 50 milligrams every 4 to 6 hours, cannot exceed 200 milligrams per day if they're taking doxylamine already. You can take Benadryl, 25 to 50 every 4 to 6 hours, or you can take prochlorperazine, chlorperazine, 25 milligrams every 12 hours rectally, or promethazine, 12.5 to 25 milligrams q 4 to 6 hours, orally or rectally. If that still don't work, but patient has no dehydration, you can add metoclopramide, which is Reglan, 5 to 10 milligrams every 6 to 8 hours, orally or intramuscularly. Zofran, 4 milligrams every 8 hours. And then Phenergan, 12.5 to 25 every 4 to 6 hours. Trimethylbenzamide. 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 Brand name. Tigan. If there's signs of dehydration, we need to give them intravenous fluid as resuscitation. We can add dimenhydrinate. Dimenhydrinate. 50 milligrams over 20 minutes every 4 to 6 hours. IV. Dramamine. Metoclopramide, Reglan, 5 to 10 milligram every 8 hours. IV. Ondansetron, 8 milligrams Q12 hours. So this oral is 4 milligrams Q8. IV it's 8 milligrams Q12. Or you can, and then you can also give Phenergan 12.5 to 25 every 4 to 6 hours. If still doesn't work, chlorpromazine. Chlorpromazine is like chlorpromazine. Um, 25 to 50 IV every 4 to 6 hours. Lorgacto. Thorazine. Or methylprednisolone 60 milligrams every 8 hours for 3 days. Taper over 2 weeks to lowest effective dose. If beneficial, limit total duration used to 6 weeks.